Hello, everyone. Welcome to all of you to the podcast regarding the monograph, The Transition of Respiratory Care from Child to Adult. I am Dorina Esendagli, and I work as an adult pulmonologist at Başkent University in Ankara, Turkey. I'm a part of the editorial board of the monograph as the early career member representative. I'm very glad to have here the guest editor of the monograph, Alexandra Nanzer. She is a consultant respiratory physician at the Severe Asthma and Eosinophilic Lung Disease Center at Guy's and St Thomas NHS Hospital in London, UK, and a senior lecturer at King's College London. She has led projects supporting general practitioners caring for adolescents with asthma, and she has published widely in the field of severe asthma. Welcome, Alexandra.
Thank you so much, Dorina, for having me.
So this is a very interesting topic, and we do not have too much knowledge as clinicians. And this is also of interest of not only pediatricians, but also adult physicians. And it is very good to have a monograph which is related to this transition process. So what does the transition process from the pediatric to adult respiratory care typically involves? And are there any specific considerations for patients with chronic respiratory conditions during this transition?
Well, you're so right, Dorina. There is not an awful lot of guidance and evidence on how to do it best. And this is exactly the conversation I had with my two colleagues, Brian Kent and Peter Barry, when we talked about transition care. Brian is an expert in sleep and ventilation, and Peter in bronchiectasis and cystic fibrosis. So amongst us, we looked after young people with chronic respiratory illnesses and have seen many adolescents transfer to our adult services during their adolescence. So when we sat together and talked about how we wanted to share what we do in our centre, but also many of our other colleagues across Europe in different chronic respiratory departments, we all learned an awful lot from each other. There are considerations that apply to all young people, irrespective of what health issues they have. And I think key aspects of transition care that comes across in this monograph is that the importance to have a documented transition plan that takes good account of the individual's health needs, communication between the pediatric, the adult, the patient, and their carer and family is absolutely top priority. It is really, really helpful to have a key accountable individual person that supports the young person throughout that transition process, that is well known to the patient and the family and vice versa. And then it is so important that this transition process, which spans over several years, focuses on education, on empowerment, and fosters that independence of the young person. Of course, then there are specific considerations that apply to the specific respiratory diseases, neuromuscular diseases, bronchiectasis, CF, etc. And that we've covered in separate chapters in this monograph.
Yes, you're totally right that we need a document to refer to because this transition already occurs nowadays. I mean, in different countries, but it is done differently, and we don't know if we are doing it the right way. So how can we ensure the continuity of care during this transition from the child to adult services? What are the strategies that might be used to facilitate the communication between the pediatric and the adult care teams?
That's a good question. I think timing is very important to start the transition process early. And outpatient clinics should be held jointly with the pediatric team and the adult team present. That's the only way that we can ensure that critical information is shared during these important years of adolescence. So joint clinics should start from the age of 13 or 14 onwards and should take place until the patient and their family or carer and the medical teams are happy that the move to the adult team is now the right thing to do or the timely thing to do. And having a documented transition plan that covers what has been discussed, what has been addressed, and what has been achieved during several of these transition appointments can guarantee that. I would encourage that parental involvement is there, although these transition appointments aim to foster independence and allow the young person to take charge. I think evidence has shown that if we involve parent in that process, the outcome is much better.
Yes, because patients sometimes, the maturation of each one is individual, so it's different maybe, and this can change from one person to person. So I think there is not quite a formula that can be applied to everyone, but to start early, that's a good point that should be done. As a doctor that already deals with adolescents, what are the challenges that you face during this transition process?
I did recognize that historically transition was mostly regarded as the responsibility of the pediatric services. And the same was the case for child health commissioners to commission this within pediatric services. And that, I feel, is not appropriate, as the transition takes place over several years. If we talk about starting at 13 to 14, adolescence runs way into the early 20s. So we're looking at care over 6, 7 or more years. And that needs to be embedded into adult services. The biggest challenge for healthcare provider is to obtain appropriately funded time for these joint clinics, but also for ongoing adolescent clinics that may include rapid access clinics to suit the adolescents' way of living in the now and support them during these critical years. This will ultimately ensure that these young people stay in education, stay in employment, and have a successful outcome and successful entry into the adult years.
Well, I think as an adult pulmonologist that I'm in a disadvantage according to the pediatricians because they have been actually dealing with this more than us.
Yeah.
But sometimes we try to continue the formula that they used up till the adolescence and continue in adulthood, which is not something right. We have to adapt it because the individual changes. I also read in the monograph that there was a chapter dedicated to the patients, and it is very important to hear also from them how they feel during this transition process. So how is the patient feedback incorporated into the improvement of this transition process? What are the things that might need an improvement in the future?
Of course, feedback from our patient is so valuable, and we were so lucky to have a patient write a chapter for us, and we're really grateful for that. Young people across the globe experience their youth and their chronic illness in a different way. There's different culture influences, there's different geopolitical situations. So it would be inappropriate to have a one-fit-all module for transition of care, and local teams will adapt to their environment. And that's why it's important that every service does get feedback from their patients and reviews their service regularly. We know that providing education, and we often use words such as self-empowering and nurturing, has a positive impact on how patients experience the transition process, give them the power to take charge of their disease. We know that parental involvement has been shown to be beneficial, but of course this needs balancing against supporting independence of the young adult and allowing them some time alone with the healthcare team. And I think taking feedback into account and embedding that in checklists that are being used throughout transition process can be really helpful. These checklists need updating with years, with new changes coming in, new treatments. Social media has completely changed our checklist because we realized what young people see as important or are guided by, and we've adapted our checklist to address that and the impact it can have on mental health. It's just one example. So a checklist-driven service that is adaptable and takes into account feedback from patient, I think is really important and supports better outcomes for our patients.
Yes, it's very important, I think, to have an open communication and make the individuals feel happy to communicate what they think that is an issue for themselves. And these can be individual problems or something that might be not in the checklist, but for the patient is important. So as you already mentioned, this can change with time according to the individual, to what they think is important or the problems that they face during this transition. And I think that it's important also for the improvement to do some research about this, because I don't know if there is any ongoing research initiative so that we can even make this better, this transition from the pediatric to adult respiratory care, go even further and get improved. Is there any ongoing research?
There's actually limited evidence in estimating the financial impact of transition care models. Studies measuring healthcare costs of young adults with chronic illnesses and intervention during the transition period are really needed if we want to further develop our adolescent services and have them properly funded. We live in an ever-changing society and are dealing with advances in medicine for new therapies. And we need to recognize that having an adolescent-specific service will ultimately provide the foundation for lifelong healthcare. But how to best fund this and have a cost-effective, positive outcome, that's where future research need to be put into. Investments into adolescent service need to consider what effect a holistic approach that covers biological, psychological, social dimensions can have, so that we can improve outcomes and lay the foundation of a healthy adulthood ahead for these young people.
Yes, and while there is always a space for improvement and to be even better in the future, how can we measure if we are successful enough in this transition process? Is there any criteria to measure the success?
There's probably fewer reports available, in particular in respiratory illnesses. But we have seen in other aspects of chronic illnesses that a well-prepared and a planned transition process can be hugely beneficial. For example, in diabetes, where falling HbA1c levels in young adults, or reduced A&E admissions with hypoglycemic events, or fewer sickle cell crises. There's clear evidence for the benefit of having a planned transition service here. In our own centre, we, for example, looked at A&E presentations for acute asthma attacks that we were able to reduce through more support for adolescents, and reduce DNA, so did not attend rates. We had improved attendance levels once we started joint clinics early, where over at least 2 to 3 years, with 6 monthly meetings with the pediatric and the adult teams, the patients were familiar enough with the adult team that the attendance rate throughout adolescence was much improved. These are small steps that we can measure and that do have an impact. I think ultimately the goal of a successful transition is healthcare costs later in life and employment rates and higher education standards as a result of good medical care during adolescence.
Well, thank you very much, Alexandra. I would like to ask you for a last take-home message from this monograph.
As a summary, I would say that recognizing that there are ever-shifting dynamics in adolescents' lives, and in particular for adolescents with chronic health issues, that as doctors and nurses and physiotherapists and the whole multidisciplinary team providing care for these young peoples, we need to be adapting our practices to support young adults during that time and really set the foundation for them to have the best possible outcome as they start adulthood. So I thank everyone who is reading this monograph, and of course, most of all, the patients who gave us food for thought to write this, and my colleagues. So thank you very much for having me today.
Thank you very much, Alexandra, for this wonderful conversation. And I would invite all the listeners to read the other chapters of the monograph, where they can have even more detailed information on specific respiratory diseases. So thank you to all of you as well, and goodbye.